a very warm welcome again to all the members of audience here who are attending this webinar today. It is the 8th webinar in its series of GAPIO Physiotherapy virtual webinar series. To inform, GAPIO is a non-profit organization established in 2011. Padma Vibhushan Dr. Pratap C. Reddy, Chairman of Apollo Hospital, who's the founder president of Global Association of Physicians of Indian Origin, GAPIO. He started it with the vision of improving healthcare worldwide with the aim to bring together healthcare professionals of Indian origin in the world on one platform. Through these webinars, our endeavor is to bring the expanded scope and the latest advances in the field of physiotherapy and other rehabilitation fields, along with the multidisciplinary team involving in, to raise this awareness to the fraternity globally. So the theme for today's webinar is stroke from neurobiology to neuro rehabilitation. Just to talk a little bit about it, we all know globally, the second leading cause of death, accounting for 11.6% of all deaths, as in a study in 2019. Ischemic stroke is the most frequently found stroke, accounting for 62.4% of all stroke cases worldwide. And it is the third leading cause of death and disability combined. If we talk of national incidence, it is about 105 to 152 per lakh people. And it is the sixth leading cause of disability in the country. Despite continuous advances in the treatment method, it is a matter of still significant concern. Many biological pathways support post-stroke recovery, fostering neural plasticity based on restorative interventions. These therapies aim to augment recovery through strategies as transcranial direct current stimulation, transcranial magnetic stimulation, robotic exoskeletons, brain-computer interfaces, telerehabilitation, pharmacological interventions, activity-based therapy, as a constraint-induced movement therapy, high-dose activity-based rehabilitation, high dose of task-specific training, mirror therapy, to name some and many more, and environmental enrichment. Structural basis of functional recovery, we all know, neuroblast migration, angiogenesis, axonal sprouting and regeneration, and functional cortical reorganization are the structural basis of this recovery, how we get it. By increasing functional activity in the somatosensory system on the opposite side of the brain from the infarction, as well as recruitment from distant cortical regions connected to the affected area, other mechanism involves improvement in the structural integrity of the corticospinal tract on the same side of the brain as the infarction. And the third mechanism involves the restoration of interhemispheric functional connectivity and the network of somatosensory sensory motor cortex on both sides of the brain. As a result, there is reallocation of function. Primary representation was damaged before. So I'm glad to share another thing that at Indraprastha Apollo Hospital, we have received a prestigious Nobel AHRF ICMR project on effect of brain-computer interface-based hand exoskeleton for neuro rehabilitation in stroke patients. And this project is in association with IIT Kanpur with the indigenous hand exoskeleton, and it will be starting soon. So our AHRF and ICMR has clubbed together and we'll be working on that project. Also, I would like to welcome today all our speakers, eminent speakers who are lined up for a sequence of 4 presentations from the prominent champions in the multidisciplinary field, comprising of neuro rehabilitation specialists to discuss a major topic, which is stroke from neurobiology to neuro rehabilitation. Here, the aim is that every intellect is going to highlight their perspective in their respective fields, emphasizing on multimodal approach in stroke management, along with what is the global scenario in stroke. They will also shed light on the advances to help ignite a healthy discourse for clinicians and academicians in the Indian community for further enhancing their scope of practice and patient care. I would like to make an announcement to put all your questions in the chat box, which will be taken up in the end. So now for the day, we have our first speaker, Dr. P. Renjen, who's going to talk on latest advances in stroke medical management for functional recovery. Dr. Renjen is a senior consultant stroke neurologist and academic coordinator at Indraprastha Apollo Hospitals, New Delhi, having FRCP from Glasgow, UK, Edinburgh, and Ireland, and with various awards to his credit as Lifetime Achievement Award in 2020, World Stroke Day Award in 2018, Innovations in Neurology Stroke Social Media Awareness Award, Distinguished Clinical Tutor Award, and many more. And he has participated and actively he's working for stroke management with initiating many projects even at Indraprastha Apollo. So now I request Dr. P. Renjen to please elaborate his talk on latest management in stroke for functional recovery. There is some technical glitch coming in his slides to be presented. Can I request Dr. Raquel Neves, having over 17 years of experience, and she is a prominent speaker. Yes, Dr. Raquel Neves, I would like to introduce you because you saw there are many technical glitches coming in. I'm sorry for that. Okay. So we are going to have a talking on multidisciplinary management for functional recovery. I would like to take the opportunity to introduce her, that she has a clinical experience of 17 years in the rehabilitation field. She's worked in UAE and Portugal. She's the former member of Board of Directors of ARN USA, an active member of European Stroke Organization, serving as chair of the Neuro Rehabilitation Committee and the founder of Emirates Nursing Rehabilitation Society. She currently serves as the Director of Nursing for Almoosa Rehabilitation Hospital. Her previous roles include Executive Director at the Dubai Physiotherapy and Rehabilitation Center and Adjunct Faculty for Health Sciences at the Higher College of Technology, UAE. She holds a specialization and master's in nursing rehabilitation and a doctorate in stroke rehabilitation. She has co-authored post-acute stroke care in the comprehensive review of stroke nursing. So over to you, Dr. Raquel.
Thank you so much for the kind introduction. So good afternoon and good evening, everyone. So my topic, I'm just waiting for my slides to go up. Yes. So today I'll bring to you in a short session the role of the multidisciplinary management for functional recovery. So we'll be approaching multidisciplinary team, what should be the components and the disciplines to be part. Then we'll be discussing shortly the conventional recovery and the difference for the functional recovery, the phases, and the benefits of the functional recovery. And we'll just go quickly for the application, the clinical application and the challenges that we are having nowadays. So our practice across the world and following the international guidelines and all the recommendations. So we are trying to build our multidisciplinary team in terms of either acute, hyperacute, or rehab and post-acute rehab, because the journey of rehabilitation and neuro rehab doesn't start only in the rehab facilities. It starts in the acute care. So once the patient is diagnosed either with a stroke or with a neurological condition, it's where rehabilitation should start. And why it's so important to approach who should be part of the multidisciplinary team? It's because new disciplines are coming to the picture, the difference between the countries. I've been working in different countries, and I've been seeing that in a specific country, we have a few services available, the other countries you don't have. So our main role nowadays is to increase the awareness of all the members that they should be and their role. So in terms of, as you can see in the slide, so we have multiple people, and it's important for the team to know the role of everyone and where everyone should have an input. So mainly the multidisciplinary team or multidisciplinary care role, it supports the organization to provide a comprehensive care and a patient-centered care with a goal setting. Especially in rehab, we talk about the SMART goals. So we need to monitor initially to have a baseline of our patients in terms of assessment and to monitor the progress and improvements to reach the outcomes. Another important role of this approach is the holistic treatment. So moving from the conventional medical treatment to holistic, where all the components, they will have an input, and to make sure that the person and the family, they recover through their journey, and they will have a smooth transition to the back to the community. To have individualized care plan, of course, we are moving for more personal care to enhance the communication and collaboration between the members of the team, because having a big team or a wide team, we need to make sure that the collaboration and coordination on the right time is not missed. The family and the caregiver involvement, it's important as we are mentioning that we want to have a patient-centered care. So the patient is the center of the care and the whole team moves, and the family has a specific role to have resources optimization and to apply the evidence-based practice. So this is briefly. So now I'll be taking us through what is a conventional recovery. So medicine has been progressing over the last centuries. So in terms of the conventional recovery is a restoration of the physical and neurological functions without a comprehensive consideration of the patient's overall daily life and personal goals. This approach normally focuses more on specific medical and therapeutic interventions, such as medication and physical therapy. And knowing from the past, there was a less integration of the cognitive and the psychosocial aspects. And we know that one of the challenge with the conventional recovery is the fragmented care model. And that nowadays we are trying to understand from the evidence base, from the research, and from the progress in the healthcare systems, and to minimize the isolation of the patients and to lead to less coordinated and personalized care. Then the new or the latest approach, that it's what we call the functional recovery, that is focused in restoring the patient's ability to perform daily activities and the participation in their community and personal life. Most of you might be recalling now the definition of rehabilitation care or some specific disciplines. But when we talk about the person and the family that needs to recover either from acute onset or a relapse, or it has a chronic condition that is degenerating, our main goal as healthcare professionals and as a healthcare system is to make sure that the person can perform their activities of daily living. So this approach is emphasizing more in a holistic view of the recovery, not only the physical, but also the cognitive, the emotional, and the social dimensions. And integrating the evidence-based practice, latest guidelines to learn from the research and to encourage the research as well, and the community participation. And why is important to mention these differences? Because across the world, we still see many discrepancies. We have high-income countries, low-income countries. So we still see differences between countries, between continents even. So it's why it's important to increase the awareness, to spread this knowledge, and to encourage. And later on, we'll be approaching the challenges. So this functional recovery that I just spoke about, it has different phases. And as I mentioned just earlier, rehabilitation and neuro rehab starts from the acute onset. And from my experience in rehab, I used to say that we used to lose our rehabilitation potential from our patients still in the acute care. And it's why it's so important for the colleagues that they are working in the neuro rehab field to be informed and to have the knowledge what are the latest treatments in terms of the acute care. And when we talk about stroke, time is brain, so it's why it's so important. So briefly, in terms of the acute phase, the main important component of this phase, and talking again in functional recovery, is the stabilization and prevention of further complications. So not only the medical stabilization, but to have a management of life-threatening conditions to make sure that the sequels and the impact, the lesions are worsening, and to have the secondary complications prevention. And here it's so important to follow the latest guidelines. For example, ISO, World Stroke Organization, they have been publishing important guidelines with evidence base in terms of complications preventions that they can be easily applied in across the world, any part of the world. Then the second phase is the early rehabilitation phase. And even during the European Stroke Organization conference last May, we were asked, when should we start rehab? When should we start mobilizing our patients during the acute phase? There is still no specific guidelines, but it's why it's always good to put the question, and we are working on it actually with our team to see if we can have a more clear criteria and guidance for everyone. So in terms of the early rehabilitation phase, so is the beginning of the rehabilitation process to improve the functional capabilities. And normally our recommendations is to start when the patient is medically stable. And the main role of these early rehabilitation interventions can be initiated and is mainly to decrease the impairments, to do the secondary prevention, and to prepare the patient for the intensive rehab that is coming. But it's so important, especially for the secondary prevention. And I still believe a long time ago when I started to work in a stroke unit, we had our protocol back on those days, and there was a lot of controversy if it was the right time after 24 hours patient is stable. What is patient stabilization? So later on, if everyone wants to share in the chat your thoughts on this, it will be interesting. Then the intensive rehabilitation phase. So once the patient is clear from the acute stage, the neuro rehab journey, applying the functional recovery model, is to maximize the functional independence and improvement of the quality of life. And why so important the multidisciplinary care is not to have just the physicians, just the nursing, and just the physiotherapists, is to have the whole team. Occupational therapies, prosthetics and orthotics, art therapy, community integration, neuropsychology, vocational therapists, music therapists, all the components are important. We do have challenges, so it's why we'll approach them at the end of this presentation. Then the next step is the community reintegration. So here, the main role in the functional recovery model is to facilitate the patient return to the community and their participation. That person belongs to a family, that belongs to a community, and we need to support through the role changes. And here we can have outpatient therapy, vocational rehab, support during the transition, home or community-based interventions. We normally approach as well adaptive equipment. And nowadays we still see a challenge in the access to the adaptive equipment and the home modifications, and access as well, and awareness of the role of the support groups and the family and caregivers education. And that's why I'm touching these topics to spread awareness. And if you have any good experience or if you are facing challenges, just type in the chat and then we can discuss later. Then another step is the maintenance and long-term management. So our patients, they are recovering from the stroke, and if they, according to the deficits that they had, might be a long life recovery, and at least in terms of prevention of complications. So this phase, we are mainly sustaining and further improvement of the functional gains. So we need to make sure that what have been gained, improved, we need to maintain and to prevent deterioration, and of course to promote long-term well-being. Normally, the main focus is to maintain the progress achieved during rehab and to prevent the relapses. Nowadays, we have been seeing in some areas, remote areas, that the patient and the family, they had a chance to go to an inpatient intensive rehab, but when they go back to their community, they don't have sometimes even outpatient service. So it's so important to have post-acute rehab discharge planning and community integration planning. So the benefits, they are well known, and they are starting now to be supported by research that is the holistic improvement, enhance of quality of life, the personalized care. Patients' feedback on this has been outstanding. Optimization of care. Nowadays, all the organizations, they need to look into their resources. So it's important to optimize our care. The multidisciplinary team collaboration, family and patient involvement, the decrease of the secondary complications, evidence-based efficiency of resources utilization, and optimization of long-term care, long-term outcomes, and the improvement in the social integration. So in terms of clinical application, our challenges, and I believe that everyone will be familiar with this. So it's coordination and communication. It's a multicultural environment and a challenging environment that every day we have a new technique, a new approach. So we need to keep up and to educate our teams. Resources limitation, different organizations, different countries, different cultures. Training and education, so accessibility and cultural and organizational barriers, patient and family engagement, standardization and consistency, evaluation and measurement, and the technological integration. And this, I want to put a note of what happened yesterday. So this, we really need to be really careful in terms of technological and integration. So I gave a little brief about what is functional recovery and the multidisciplinary team approach on this. And this is what the latest evidence-based and guidelines across the world are advocating for. And we know that every community has different challenges in terms of application, but there are different ways of applying this, and it's a progress. So if we don't have it today, let's work to get it in our facilities, in our organizations for the future. And sometimes it's these small steps that we need to monitor the outcomes so we can share with the other colleagues that they are facing similar challenges. So it can give them maybe not the solution, but the support for them to achieve similar. Let me know if you have any questions.
Thank you, Dr. Raquel, for such a wonderful and a wholesome presentation. Exactly talking about all phases of functional recovery up till social integration, because in India, it's little different when we are working. Once the person goes to community, it is majorly the family taking care of. But it is a good thing. I mean, we getting the wholesome presentation from your end. Thank you so much for your thoughts. And I believe we can have question answers at the end of the presentations. So thank you, Dr. Raquel. And now I would like to invite Dr. P.N. Renjen with his presentation on the latest advances in stroke medical management and functional recovery. As I had introduced him, I would like to reintroduce him again. He's a senior consultant, very, very energetic stroke neurologist and academic coordinator at Indraprastha Apollo Hospitals, New Delhi, with multiple FRCPs to his kitty. He has been awarded with various prestigious awards like Lifetime Achievement Award and the award as Individual Achievement in award at Stroke Social Media Awareness. He's a distinguished clinical tutor and he has been awarded as Legends of Neurosciences. He has been very, very enthusiastic in promoting stroke rehabilitation in the community in India. Over to you, Dr. P.N. Renjen.
Good evening, everybody. Thank you, Dr. Seema Grover, for asking me to be here today. And I'm really honored. And my topic, which you have given me, is to talk about the latest advances in stroke medical management for functional recovery. I think it's a very excellent way of putting it. We all know that tremendous amount of research and work has gone on in the management of stroke, right from the days of the TPA, 3 hours, 4.5 hours, thrombectomy, and now we are even talking about thrombolizing since 24 hours. Now, how does a good stroke management, medical management, impact the functional recovery of a patient, and what all we can do to enhance the functional recovery? I'm one person who very strongly believes that rehabilitation at every stage of the illness of stroke is very, very important. Now, let us go through what are the mechanisms of functional recovery. Can I have the next slide, please? Now, I would talk about what is called neuronal plasticity. Now, what is neuronal plasticity? It is the reorganization of the ipsilateral and contralateral cortices adaptation. 2, it's a co-activation which has a role in functional improvement, but its role is still not clear. Then we have the structural basis, which is neurogenesis and angiogenesis. Now, what is neurogenesis? Evidence of migration and repair mechanism post-stroke. 2, angiogenesis, supportive role in tissue repairs and neuroregeneration. And the third important one for the mechanism of functional recovery of stroke is promotion, growth promoting environment, and in a cortical map reformation, and what is called inhibition of a NAGO-A protein, which limits plasticity, where NAGO-A antibodies are showing a promise in improving the neural plasticity in our patients of stroke. The next one, please. Next one, please. Okay. Now, what is the functional cortical reorganization? There is a peri-infarct and there is contralateral cortices, which shifts the cortices in the activation process. A very important mechanism, which is called diastasis, which is reversal of functional improvement as a recovery mechanism. So what I mean by this mechanism is that you have an area of infarction, which is structurally damaged, but there are other areas in the ipsilateral and contralateral part of the brain which are functionally involved, which are not structurally damaged. So this absolutely adds on to the neural plasticity. There's certain specific issues in intracerebral hemorrhages. Thrombin at the site of the hemorrhage has an interesting role in neurogenesis and angiogenesis. The statin therapy, we all know statins, has a potential benefit in recovery process in ischemic stroke Now the work is also going on that statins are useful in hemorrhagic stroke. There's certain pharmacological and certain non-pharmacological intervention. Central non-adrenergic stimulation affects the recovery growth. Serotonergic and dopaminergic, they are mediation of brain plasticity. As just mentioned by my previous speaker, that in the conference of the European Stroke at Basel a couple of months back, we were discussing about L-DOPA's role and the role of serotonergic agents in the speedy recovery of these patients. And I, for one, have been using duloxetine and L-DOPA's time for neuronal plasticity and neuronal recovery. Then, of course, non-invasive cortical stimulation, which enhances to improve the recovery. The clinical application of all this, everything has to have a clinical application because everything is to be oriented towards the patient. The constraint-induced movement therapy promotes motor recovery via cortical reorganization. And challenges are optimal recovery mechanism vary among patients to patients. You can't have the same patient having the same recovery reasons we just talked about, depends upon a number of factors. Next. Now, this is a very interesting paper which I just picked up. It is implementing robotic assisted grade training in acute inpatient stroke rehabilitation, a quality improvement initiation. Raquel just talked about this. And I have been discussing this with Dr. Seema also of acute inpatient rehabilitation. Now, the last word has not been said, but I think we have to really, very seriously look at starting rehabilitation in the acute stage of the illness. Why I promote? Because there would be large amounts of dopaminergic drugs we could use. We could use serotonergic drugs for acute recovery in stroke. Can I have the next slide, please? Now, ladies and gentlemen, you see this beautiful slide. It's very clear. The yellow one is the robot assistant physiotherapy, and the blue, which you see, is non-robotic. And you can see from yourself that what difference it makes between a robotic assisted physiotherapy and a conventional physiotherapy. Next. Based on these results, it has been seen that patients with stroke and lower levels of functional mobility benefit from robotic assisted locomotor training in the early phases after injury. Next one. Conclusion. My conclusions are very clear. Various new approaches and technology advances have promising results in improving recovery after stroke. I would like to stress about one thing again, that we should utilize these advances, whether they are pharmacological or non-pharmacological, for stroke reversing. These therapies enhance neural plasticity and help overcome challenges of rehabilitation access in order to provide an adequate dose of rehabilitation and improve adherence and participation. Next. Ladies and gentlemen, we have a channel on stroke neurology. I won't talk about that, but I will just end by saying, please appreciate the newer advances in stroke rehabilitation, and you can change the life of a patient and an individual and get him back to normal quality of life. Thank you very much, Dr. Seema.
Thank you so much, Dr. P. N. Renjen, for such a specific, precise, to the point talk, which really spoke well about pharmacological and non-pharmacological management of these patients to minimize their disability. And also for the people's information, we at Indraprastha Apollo Hospital have recently started with robotic rehab. So it is a great effort from Dr. P.N. Renjen's side also, because he is a great promoter of functional independence of these patients and whatever best can be done.
Thank you,
So,
madam.
thank you, sir. So next, now I invite and introduce our next speaker, who's Dr. Teck Chye. I hope I spoke correctly your name, on the advances in robotic rehabilitation for functional recovery. To introduce him, he has been working as a physiotherapist in Singapore with a range of experience in the acute hospital and community settings. He has experience with neurological, orthopedic, cardiopulmonary, musculoskeletal, and sports patient. In 2023, Teck published in International Journal of Environmental Research and Public Health. His interest lies in technology in improving clinical outcomes for neurological and geriatric patients for their rehabilitation. He participated in Singapore-Stanford Biodesign program with insights into medical technology, startup process, as well as go-to-market strategy. He is a certified instructor for multiple devices from DIH, that is Locomet, Indago, Erigo, Armio devices. So over to you, Dr. Teck, for your presentation. And along with him, we have Dr. Anak from DIH. So over to you for your presentation.
Thank you very much, Dr. Seema. And I also like to say very honored to be at GAPO. Very warm welcome, very happy to be here. And I'm also very honored to be receiving this, being part of this talk right after Dr. Raquel Neves. Wonderful sharing about the clinical guidelines, how multidisciplinary teams are important in terms of shaping care for patients. And then we also had Dr. P.N. Renjen to share very, very insightful pathophysiological approaches, as well as the basis of neuro rehabilitation, the concepts like neuroplasticity, cortical reorganization, very prescient sharing. And I also truly appreciate that the support that Dr. P.N. Renjen has for the use of advanced technologies, use of pharmacological and non-pharmacological approaches to best and maximize patients' care, even in the acute stages. So today, myself, I will be sharing a bit about the advances of technology in stroke rehabilitation along with my colleague Anak. And we are going to touch on what this entails for rehabilitation scene for the next few years to come. So like myself, Anak is a clinical application manager for DIH, Asia Pacific. Both of us are physiotherapists by training, and both of us are certified for multiple devices. So the emphasis of this will be more on the role of robotic technology in stroke rehabilitation. So as we know, with this global trend of aging population, of course, in India's circumstance is slightly different due to the larger population and the trend of Indian patients to be slightly younger as compared to developed countries, Australia, UK, and Singapore. So we do see that trend, but it probably takes a while before this prevalence catches up for India's context. Nonetheless, we see an increasing prevalence in neurological disorders, and then states that there's large demand for skilled therapists across healthcare systems. So regardless of the countries that we're talking about, developed, developing, etc., there is a significant lack of skilled therapists. And so the goal is to provide same or even better care while tackling the shortages of manpower. And how do we do this? We aim to maximize clinical outcomes, but we also ask ourselves, how can we integrate technology in this? So when we examine stroke patients upstream in acute care, we know that this is often a race against time. Why? As Dr. Neves mentioned, there's no clear indicator as to whether the care should be started in acute phase or slightly wait a little bit, within 24 hours or a bit longer. But of course, we also noted Dr. Renjen said we should start it in the acute care as soon as possible. And so, yes, both of these points make absolute sense. But what matters the most is that we have to ensure that patients are medically stable, as mentioned by Dr. Neves. So things like medical contraindications, it's a balance, patient's ability to tolerate rehabilitation. And then, of course, we try to maximize the amount of rehabilitation, the dosage and the intensity to what the patient can tolerate. So I'd like to bring your attention to the middle of the screen, where we have this study by Dr. Grefkes. So Grefkes et al. Noted that when we examine the recovery trajectory for patients with stroke affecting upper limb function, we know in the Fugger-Meyer upper extremity scores, we see that there's actually an exponential increase prior to week 5. And post week 5, in some cases, the scores start to plateau. This does not mean that this applies to all patients. It just gives you a rough indicator in the large prevalence, large distribution of patient population. There's a trend. And the trend is that we want to start early. Rehabilitation starts early. Why? Because we want to leverage on the fact that cortical reorganization, neuroplasticity starts to increase at an exponential rate before it starts to plateau with time. And hence, clinicians are always in a dilemma in the acute and subacute setting where they are trying to balance this fine line, walking the tightrope between medical stability and safety versus maximizing the dosage of rehabilitation. And then we also note this. Even though this talk is focusing on stroke, I would just like to highlight your attention to traumatic brain injury. So we can see on the right side, a very similar pattern where there's a steeper gradient in most, if not all of these domain-specific outcome measures, where patients experiences increase and a steeper gradient, and then this starts to plateau after the 4th month. So of course, if we look into the timeline, we note that, for stroke, some previous studies out there suggest that, this exponential increase could be up to 6 months. But we can see over here for traumatic brain injury, the concepts of neuroplasticity, cortical reorganization, they all do apply likewise. And that we are looking at a window of 4 months, perhaps longer for a few patients, perhaps shorter. And so then this again underscores the need for clinical rehabilitation to be provided to patients to achieve better clinical outcomes. So beyond early access to rehab services, there's a need to provide high-intensity training based on established neuro rehabilitation principles, including task specificity, functional training, high repetitions, tailoring it to patients' ADL, activities of daily living, or even gait training. So in the next slide, we have this study by Gunduz et al. So in this slide, what I wanted to highlight is actually the technologies available. So we have vagus nerve stimulator where you have an implanted stimulator connected to the vagus nerves. Of course, the idea is to stimulate the vagus nerves to promote new recovery. But there are some practical challenges in this where patients have issues with compliance in terms of comorbidities that may make patients contraindicated to the type of device being used. And then we also have transcranial magnetic stimulation. So this is where EM induction coil is actually placed over the patient's scalp. In some instances, TMS is actually used more as a diagnostic tool to determine the brain activity. In other cases where it's used with repetitive clicks, then it'll be treated as an intervention. And of course, the proposed mechanism of action is to deliver focal electric currents to the brain to depolarize neurons and act as a mode of intervention. So following that, we also have the transcranial direct current stimulation. Low amplitude current is direct current is actually applied to the patient's skull. And the goal is to actually create some stimulus to influence polarization and neuronal firing. So in these instances, we know that neurons require a certain amount of action potential before they can produce and send the synapses can send electrical signals firing. So in post-stroke cases, in some circumstances, there's a inability to create enough polarization to cross that threshold. So I believe this is where the TDCS comes into play. Something that personally Anang and myself are a bit more familiar with would be the robotic assisted therapy. So robotic assisted therapies have been in the market for over a decade. In fact, in some instances, 2 decades. And that there's multiple studies showing the safe and positive effects of the use of robotic assisted therapies to integrate it with gait training, integrate with rehabilitation. And then we go back to what is the mechanism of action that facilitates robotic therapies to provide such successful clinical outcomes. Repetition and intensity are the key factors. What do I mean by that? When we go back to Dr. P.N. Renjen's excellent talk, we noted that we have cortical reorganization, the motor mapping, the increase in neuroplasticity, and all this are the result of high repetitions with higher intensity tailored to the patient's needs. Beyond that, we also have virtual reality. So conventionally, virtual reality is actually classified into 3 types, namely non-immersive, semi-immersive, as well as fully immersive. So the existing evidence leans towards immersive systems having beneficial effects for upper limb rehabilitation to produce results in motor recovery. But what we need to note is that the use of virtual reality for the improvement in motor recovery can be achieved whether we combine non-immersive or semi-immersive VR with conventional therapy. So they have to act as an adjuvant for the patient care. Lastly, we also have brain control interfaces where patients try to use their ability to initiate movements and gain control of robotic devices. How this is done? It translates the brain signal through physiological activity, bypassing the area of lesion, and that goal is to actually promote and enhance neuroplastic feedback with motor imagery and sensory feedback. So having examined the various technologies available, we can then do a quick comparison of traditional modes of care from a clinical perspective to use of robotic technology. So what are some of the common gripes that patients have when they use the conventional methods of care? Firstly, we have limited mobilization. For patients who have severe disability, this can be highly labor intensive in terms of work for the patient, work for the therapist, in terms of the staff ratio. In some cases, we know that patients require 2 to 3 maximum assist, and when we try to ambulate and we try to enforce physiological gait patterns onto patient, we know that this is laborious for all involved. And then therapy in these instances are limited in variation. The durations are limited, and we cannot quantify these trainings objectively. And lastly, the ergonomics of therapists is being sacrificed to benefit the potential recovery of patients. So in such instances, what we aim to do is to integrate existing or upcoming technologies into patients' care while we try to maximize the clinical outcomes and reduce the downsides to therapists. So how do we achieve our goal? We aim to utilize robotic technologies to titrate the workload and provide physical assistance to challenge patients as tolerated. We want to emphasize early start to the trainings, make it more intensive, make it high repetitions. Do you recall the graphs which indicate the early rehabilitation provides better outcome in maybe 3 slides before? So we know that the goal is to actually seize this window of opportunity to maximize clinical outcomes. Subsequently, we integrate task specificity. How do we do that? With the ICF model, we can identify what our patients' priorities are, the structuring of the rehabilitation to suit their needs, and therefore create this specificity to direct the activities that we do for our rehabilitation sessions. So we know that there's motor sensory integration. We also need cognitive participation from the patients. And thereby, we are using the virtual reality to engage patients better, to improve the amount of motivation, especially when we talk about rehabilitation sessions that, extend to over 20, 25 sessions. And we know there are some instances where this is the amount of duration that patients require. And lastly, we want to provide correct feedback. We want to ensure that data is being tracked from the patient's participants. We can quantify it. We can monitor over multiple sessions through the use of robotic devices, and then we can repeat the treatment methods across different sessions. So you can see over here is just a brief summary. In terms of intensity and dosages, we want to increase it. We want to create some degree of specificity for treatment, and we want to maximize the amount of participations that patients have during our sessions. And this is just a rough integration of how, when we have like a conventional stroke patient, we have the picture of trying to restore their function within this golden period of first 3 to 6 months, and even earlier, in fact. And of course, the goal is to get the intensive rehab through task-oriented movements, and we want to use robotic devices. So moving forward, I'll have my colleague Anak to share slightly more about our company and the products that we have. Anak, over to you.
Yes, thank you, Chye. Thank you, Dr. Seema. This is a good time for DH. Our organization really appreciate it for to do some of the presentations, brief up about the technology in terms of rehabilitations, especially for the robotic rehabilitation. Yes, thank you, Chye. From the background and evidence base of the rehabilitation, of course, we need to moving forward for the advanced technology. What's the goal of us? We just aim to the quality of life after injury. So that is the goal of us. In terms of DIS at the grants, you can see for all devices of us are commercials and launching in the global market. We have a section of the research and section of hospital and clinics as well. That is our reserving to the patients and to the organization. Not only that, in terms of the reality, we are serving for the augmented feedback, and also we are as well. Under our brands, we are combining together from Hokuma and Motec. Maybe the Hokuma is the one of the first company in the world to produce the robotic exoskeletons, naming Locomat. So the Locomat first version was done on 1998. Until now, we have 6 versions of hardware of Locomat with 11 versions of software. Not only that, another part of the DIH, we have Motec. So the Motec, they are really integrated to the research market, setting themselves to the research tool and the functional of the research by treadmill and walking. This is our global organization. So once we are here, India also under the taking care of Singapore Asia Pacific Hub. we are mostly commonly in terms of cultural. So that's why the regions taking care better than other regions taking. That's it. Under the products of ours, yes, we are the nameling of the CE marks of the Europeans. And right now, MDR is the one of the interesting for the following SL. Not only that, in terms of our health provider and organizations, the research facility is the one of we are taking care for on the market. Rehabilitation hospital, physiotherapy, and rehab clinics, sport institutions also are the ones of the health provider for us device. Not only that, in the market of us, we are going to throw market by starting for the neurological market and rehabilitation. After that, the expansion of population of use of the device need to focus and control for the order of population, for example, like pediatric, orthopedic, and aging population. That's why when we are talking about the locomat, we are aiming to get and balance impairment without naming by disorder. This is a continuum of care. So once we are here, we know well we need to routing the device to the FAC score. So functional ambulatory score is the one of we are using to mainly device of us to level the eye of us from severity to the good recovery. That's why we are starting from the Origo, Locomat, Endago, Ryzen, and CMU when we are talking about the quality of care. The next slide is just showing you for the continuum of care for arm and hand rehabilitation. So in terms of this slide, they are coming with the family of Amio, starting from Amio Power with passive assist step, Amio Spring, active assist step, and Amio Sensor without the exoskeleton, but they are coming with the sensor base of the device.
Can I request to wind it up as soon as possible because we are very, very short of time and we are already oversleeping. Thank you.
Thank you, Anna. So I'll just like
Yep.
to wrap up saying that we are very, very happy the VIH are very proud to partner Apollo Indraprastha. And Apollo actually is one of the leading hospitals in India. They have the Locomat, Erigo, Endago, and Amio Spring. So of course, if you're interested to know how these devices are being used, do reach out to Dr. Seema. Thank you.
Thank you so much,
Thank you.
Teck and Anna. And now we have our, without taking any other minute because we are already oversleeping. And so I would request Dr. Sapna Chakraborty to take over. And before that, I would like to introduce her. She is an associate professor and a program director of doctoral programs in occupational therapy at Missouri State University, United States of America. In her doctorate, she emphasized on neurocognitive rehab and constraint-induced movement therapy, which we have just heard in previous slides, but now she's going to throw a good insight into it. Her work experience includes outpatient acute care rehab school systems and teaching at doctoral and master level of OT programs. She's been an administrator at the nursing home, private practice, and university for 10 years. Her research interests include stroke rehabilitation in children and adults, autism, and interpersonal education. She consults with the Neurodevelopmental Center of the Ozark to provide occupational therapy for individuals with neurological conditions of all ages, conducts training for students, parents, and teachers caring for individuals with neurological conditions. She has been invited to various countries to present her work as the role of occupational therapy in neuro rehab at various conferences across the globe, South America, Trinidad, Australia, and France. So over to you, Dr. Sapna, with your presentation.
Thank you for the kind introduction, and it's an honor to be part of this esteemed panel. I'll try to most of the points all the speakers have, and I want to reinforce some of those things and share about how occupational therapy plays a part in this specific condition. In my slides, I've included the incidence, the location, the time frame of recovery, factors impacting the recovery, some OT specific precautions, some evidence-based interventions, and some of the new research updates. As you can see, and everybody has talked about, that stroke is, globally the second leading cause of death and also causing the disability. So we have a very important role as a multidisciplinary team, like Dr. Raquel said, to help these individuals, go back to community and their social roles they were had before stroke. This slide, mainly I put it in there. Most of my clients I see, with the stroke has middle cerebral artery issues, and then some in the posterior and the anterior cerebral artery ischemic when they have stroke. So why did I bring that up is because a lot of the patients you'll see who come to for rehab, if they have a middle cerebral artery, the most affect is the face and the upper extremity, and versus, lower extremity. Whereas if they had an anterior cerebral artery affected, then you see the more lower extremity affected. And those are the more severe stroke clients. The other thing in this slide I want you to pay attention to is it's not only the motor part which is affected, we have these clients have apraxia, they have aphasia affecting their language, they have sensory issues, they have visual issues. So as in the rehab team, we need to pay attention to all those things for the best recovery of their function. Other than all this symptomology I just shared, that there is another layer of complications which can impact their recovery. How much motor deficits they have, if it's severe, it's another layer. If they have poor sitting balance, adds to another layer. If they have incontinence with bowel and urinary, we know that makes it even harder for their prognosis. If they have a vision issue, they have a cognitive or psychosocial issues, and they have aphasia, that even adds up to our, patient's care and coming back to their recovery. So again, everybody said it is very important, the time frame in these individuals. Like we want to see largest percentage of the motor and all the cognitive recovery is happening in the first month of stroke. So in US, it's almost like a gold standard that the rehab starts right when they are in the acute care in the hospital, when they're admitted, as early as, the first day. At the most, you are there on the second day helping them. And then in the next 6 months, it might be a little bit slower. And even, later in the post 1 year, the recovery is becoming a little slower, but we do know that in each of these stages, rehab has a great important role in a different way, and you can help these individuals, depending on when they come to you and which setting you are helping them in. This slide, I put it in to keep it when they're in the acute stage, the things you have to help, the caregivers and the nursing staff and other who are helping them to keep in mind while they're recovering. The biggest one is looking at not only at the vitals, but looking at their upper extremity, while they're helping them in the bed or bringing them up or sit, doing different activities of living. Really at the acute stage, if you, help them restore their, the upper extremity range of motion, this is the time when, you know, we help them position very well. Sometimes we have to build some orthotics to help them support that weak arm, so they, when in the future they're recovering, it is there for them to use for their functional activities. The other one in this stage is swallowing precautions. A lot of the patients I've seen, if you're not aware of if there is the consistency of the food they're eating. So OT plays a really important role in looking at that they are not choking, or, you know, don't get all the respiratory issues and have some complication as bad as pneumonia. So swallowing is another role. As an OT, you make the caregivers aware of what kind of consistency you're feeding them at that time, at that stage. This is the assessments we usually use in US to figure out how severe the stroke is. And I also put some of the OT specific assessments on the motor function, the Fugl-Meyer, the Wolf motor function. But other than motor, testing, we are also looking at their vision and cognition, how much it's coming back, and what kind of strategies we can show the caregivers or the nursing, staff who are there with them all the time to help them figure out how they can help their clients all throughout the day. In this stage, like I said, even though it's a motor control we are looking at of the arm coming back, but it also not only the strength and endurance, which is affecting their functional performance, but it's also their ability to learn the return of the function we are wanting them to have. And that motor learning is affected by their vision, cognition, their spatial awareness, and their sensory, which we forget that these individuals can also have some sensory impacted. I've seen my patients telling me, my arm really feels very, heavy, or I cannot feel it as good as my other arm. So really paying attention to all those symptoms other than just the motor control we're helping them in. This slide, I put it in to share with some of the apraxia issues I see in my clients. Sometimes they will come and we'll be working on their activities of daily living. So they have a brush in their hand, they start using it as a comb. So that shows that they have an ideational, apraxia. Sometimes they even know that this is a comb, and I tell them use the comb, but they're using it backwards. Or if they have a clothing, they will start putting their pants into their arms or their shirt into their legs. So all this is showing us how, their apraxia is not back yet, and the things they need help with, learning those skills. The other than apraxia, I've seen in my patients, they have lots of attention issues, orientation is affected, memory is affected, a lot of executive skills, the time concept, the organization, all those things. They're very impulsive, they're not very safe around in their environment, so that's all related to, where the lesion is and the cognitive stuff. The other thing I put it in here is agnosia. We usually don't, pay attention to, but some of these people don't even know. Agnosia means like they don't even know what they're hearing. That's why the commands you're giving, they're not able to follow. The color concept is not there, the size and weight. Prosopagnosia is they can't even see recognize the faces of their family members. Or even if you show them like a historical figure, they won't be able to tell who they are because they have agnosia. So keep all those in mind. And then at this stage, after they recover a little bit, they are able to do their basic activities of daily living, but that doesn't mean they're ready to be discharged because they have all these cognitive issues. Will they be able to go home and be by themselves? Will not be very safe for them because they're still dealing with all these other issues. This is a little slide in showing how vision effects can be, depending on the lesion. So it's not just the field of the vision is affected, it's the attention, visual attention you need to pay. You can look at, and a lot of my clients have neglect, they have neglect also is it their own body neglect, or is it their understanding of their body in space? So there's a lot of spatial neglect is going on with these clients that you have to keep in mind when you're doing or helping them in your rehab. So this is a simple test for the unilateral spatial neglect. You can see, drawing a clock, like where can they actually are paying attention. Just give you a little bit insight where they are. So as an OT in US, you start right away in acute phase, and that has shown in the research. Earlier we get into for the care, better results we have. So in the acute care, you're looking at their skin, you're looking at the positioning, giving them splinting, bracing them, showing the nursing to really help to maintain that soft tissue. So when they're ready to go for some intensive rehab, we haven't lost that. We haven't have the subluxation there, or you still be able to preserve what they have. Safety, trying to stimulate, as soon as, even if they have lots of medical lines, with a G tube, you see in the picture, they have a G tube, their IV, they can still sit up, they can still sit up and help you learn to, get their control of their body and start stimulating some of those hand muscles to comb them, wash their face. So it just showing the staff, you are there only for 30 minutes, but they are there for the whole day, how they can help and stimulate throughout the day. The next phase, I know Dr. Raquel had talked about different, very nicely, all the different phases. But the rehab phase is another one. As an OT and PT and speech, we work together as a multidisciplinary team with the nursing to help them do this therapy for as intensive as 3 to 5 hours for 6 to 7 days for 6 to 12 weeks in rehab hospitals. We have these clients all, through this better, more intensive and better results we have seen. But if the patient does not cannot tolerate that pace, then they are sent to the nursing home, but they can still get therapy at a slower phase. But in this phase, we are really showing the client how much they are recovering, and the family is really focusing on the lost, function. But I always try to tell the caregivers and other staff that let's start looking at some adaptations, even though the return is not there yet. But if we environmentally, if we can adapt their environment, we can give them some tools which are adapted and give them some compensatory strategies and start looking at some alternative roles that the patient will be prepared to, for going back to their home and community. It will really help them in that phase to figure those things out. As specific occupational strategies I included in here, our gold standard is constraint movement therapy, and it's nothing, big about this. You can start as simple as, if you see in the picture down here, just put a mitt on their good hand and force them to use the other hand to feed themselves. Use them to write with the adapted writing utensil, drawing, use that affected hand as much as you can. Is the main goal for the constraint-induced movement therapy, and has shown really great results in any kind of dosage. I know more dosage is better. We have found, the intensity has been from 5 times a week to 3 times a week to 2 times a week. But whatever you do, if you use that constraint on their non-affected hand and force it earlier, better the results are. I have also, supplemented my CIMT with the Botox, especially on those, if the spasticity is there in their affected hand, in the pronators and the wrist, is really helped me along with the CIMT. I've also used aquatics. I've used neuromuscular electric stimulation. I really like to, and always recommend to use the FES and NMES in all the phases, because it really keeps their hand, not only stimulates in the acute stage and rehab stage, but even after, maintains the circulation, maintains the range. If you have them on that plan, it really helps them to keep that going. the task-specific training, everybody just before me, all my esteemed, speakers mentioned how repetition is very important in this condition. More you repeat, more you reinforce, more times you do the activity, it helps them to have that cortical reorganization, and all that plasticity kicks in. Mirror therapy is another good one we use in our clinic here. And then the cognitive training, just like Mr. Ten just shared, how the virtual rehab can really help. It is also gives the patient really great motivation. If you can see in the picture, I use that even with the not in the very first stage where their arm is not able to, does not have enough return yet. I use this mobile arm support to support their arm. And now we have robotics. I don't have it in my clinic yet because, it's all funding if we do have, but that's has shown really great results, especially has hope for low, where the return is not there yet for those clients. It will give really big hope to those clients and start really early and show them how to use it. So in this picture, I have this virtual rehab screen where they can simulate working in a kitchen or, going to groceries or things like that. You can customize on those visual screens. In the second screen, now the return is back. So I involve the clients with some gaming, they really enjoy, and helps them to do those repetitions I want them in their arm, and will help them in their functional recovery later on. And then some immersive VR has come up, is really a great tool to use, for rehab. Just really quickly, I know with the rehab and working as a therapist, you are with the client only for 50, maybe 60 minutes a day, or maybe twice a week, at the most 3 times a week. But most of the time, the family is with them. So my main aim is to help them, bring them to the session, really learn what I'm doing in the session with the family, give them written instructions, help them do the things right in front of you, repeat, more the patient will do, better they get, and better functional recovery they will have. The other big thing is not only look at their self-care and activities of daily living, please pay attention to their leisure routines. If you will really see what the client is interested in, they will have better recovery. I always tell my clients, even if they're learning to still walk with a device, they have a walker or a cane, but also have a wheelchair, because if they can't walk long distance, if you have a wheelchair, a family member can take them in the chair. They can, enjoy all the family activities. They can go to temple, they can go to a church, So more they're involved in their leisure and other activities, better is the recovery, the functional recovery overall. This slide, I just put it in here because OT in US is very involved in driving, because a lot of our individuals, they have been professionals or they live by themselves, and driving is a very important, a daily living task that we have to help them to get back to. So we do lots of different specific evaluations, vision, cognition, problem solving. Once they are able to do that, we help them do on a simulator, and then also we do some road testing, and then they are able to go to driving. This car actually has been, they transfer from foot operated to the hand operated, and then sometimes you can move even their foot from right to left, feet, depending on what stroke they had. So it's a great thing to teach the teacher. We help them to learn. And these are some of the latest research I came through. I put it in the references. Everybody is welcome to, reach for it. But more and more randomized trials are done with all the things, with all the speakers have talked about. Combination, I find if you combine the modified CAMT with the, the brain stimulation we are talking about, you combine the task-based specific training with the mirror therapy, there's better results. So it's a great place we are today. And, you know, there's so much going on all over the world that we can help these clients to be, you know, back to what they were doing before, or find them an alternative role and be back to the community. So that's my slides, and here's my references. All hopefully you.
So much, Dr. Sapna. Thank you so much. I believe I would really like to thank all the speakers, but at the same time, I feel that now we have, though it's so interesting, we have overseen the time, but still, I would say that it has been summed up so well. So now we have our two eminent personalities who will moderate the question and answer session. And I request all the audience, if they have any questions, they can put it in the chat box. So I take the honor to introduce Dr. Raj Prasanna and Dr. Hannah Rajshekar, who will be moderating the question answer session. Dr. Raj Prasanna is Head and Chief of Physiotherapy and Rehabilitation, Chennai Division, and he is Principal to Apollo College of Physiotherapy at Chittoor, with 24 years of professional and clinical experience, including academic and research activities in the field of physiotherapy and rehabilitation. He is member board of examiners to various universities in southern India. Along with that, he has delivered and managed state-of-art treatment facilities in India. And I would like to take the opportunity to say that first in India, when the robotic neuro rehabilitation was introduced, it was introduced in Chennai, which is way back 1.5 decades. So heading the facility at Chennai division with a staff of 105 physiotherapists under his collar or banner, I would like to now take this opportunity for Dr. Raj Prasanna to be here. Along with him, we have Dr. Hannah Rajshekar, who's founding principal of Apollo College of Physiotherapy, Hyderabad, with a master's degree in physiotherapy and clinical certified pelvic floor rehab specialist, certified dry needling therapist, and she's a PhD scholar also. She is member to research committee of AHERF, HOD of Orthopedic Physiotherapy Unit in College of Physiotherapy, state coordinator of IAPWC Telangana, with a rich experience of 34 years, where she has worked as a clinician, academician, administrator, and a researcher guiding students with various awards to her kitty. Now I put the forum open for them, and I would request Dr. Raj Prasanna to give little insight on how their journey has been with robotic rehabilitation. Over to you both. Dr. Raj, you're muted. Please unmute. Unmute him.
Okay, good evening, everyone. It was really a very beneficial session that we had, holistic approach from, each of the speakers. I really enjoyed listening to each and every one. And I think Dr. Raj is unable to, get his mic on or something. So there's a question here. We would go into that. So that'll be, taken up. It says that should we rely more on neuro-robotic rehabilitation for better and faster progression of patients? Or should we use 50% to 50% combination of neuro-robotic rehabilitation and traditional method? What would be your take on this? Can someone please throw an insight into this?
Sure. As an OT,
Yeah.
all the treatment strategies are updated, like robotics have come up. I have always tried to combine. It's also your clinical judgment, and it's also the patient you see and what, stage they are will help you to find out what should it be, 40-60, 20-30, 20-80, it depending on where they are, and then what, So for the robotics, I have done my training. They always tell you to combine. You always combine with your traditional treatment. It's not just robotics that will, help them to get all their goals. So for me, it's always a combination.
So there's another question, Dr. Sapna would like to know how important it is to adapt or change the techniques utilized at the right time as per the stage of stroke recovery.
Yeah, again, this will depend on what strategy it is and, what is the deficit you are dealing with will help you make that clinical decision, Like I said, say, I have a client who has really severe stroke and has no control in their upper extremity right now. So I think the robotics, it'll be such a great tool for me to help, like I have done. I've used that mechanical mobile arm support to, adapt to hold them. Then once they start getting the return back, they have all those, great movement patterns there to actually use that for some function. So hopefully that answer your question.
Okay. Actually, I'm really, happy to hear this whole session. I can see that this is dealing with a lot of advanced techniques. But at the same time, we said, giving importance to the traditional techniques. And I feel that's very important because if you look at community level, everyone can't be exposed or have the facility of this robotics, isn't it? So our traditional way of treating patients doesn't, stop there. And we need to know also when to use that at the right time.
See, madam, there is no doubt about that fact that the traditional methods of treatment will continue to be of use in centers, and all centers will cannot afford to have a
Yes, doctor.
robotic assisted physiotherapy program. But we must also understand that there are solid shortcomings of conventional old age physiotherapy over the robotic assisted neurotherapy. So we must understand that whenever the facility is available, we should be clear that what sort of patient need to go to a robotic assisted device physiotherapy, because undoubtedly, if you compare the two methods of treatment, robotic assisted is far better than the conventional therapy.
Thank you, doctor, for showing so much faith in, the new techniques. And
I would like to add one thing, Dr. Hannah.
Yes.
Definitely, as we have spoken about, that robotics cannot be procured or at all the centers. For that reason, now many Indian companies or engineers are getting into it to get it done. The way we are going to have a second phase trial on one of the hand robotics, which is indigenously done with the IIT Kanpur. So ultimately, even if it is a robotic equipment, it has to be the person behind to understand what is the nitty-gritty of the functional loss on which you have to utilize it. I would like to put it like that. We have Dr. Raj Prasanna with us, and he was traveling on my request. I believe he's on his way somewhere and he stopped himself. So, Dr. Raj, without taking much time, I would just like to ask you that 15 years of robotic rehabilitation at your center, what you have to say about, like we were having a slight kind of debate that whether robotics is good or conventional is good. So you have worked with robotics, and what is your view on this?
Yeah, first, thank you, Dr. Seema, for the wonderful introduction. I think there was some connectivity issues. I couldn't join immediately. Thank you all the speakers for the wonderful presentation. And the team from Hokama did a very good presentation. Thank you all. And coming to your question, we have been using these robotics for the past 15 years at Apollo Chennai, and we are the first in the country to have this facility. And apart from Singapore, I think in Asia, the Apollo Chennai had this facility for the first time. And now we have revamped our old equipments and we have taken up the new versions of Hokoma. And the main thing what I wanted to tell is the company is the Hokoma and the DIH is totally into research, and they continuously they upgrade their equipments based on the feedbacks received from the customers. See, we were just talking about all the equipments, and there was a debate regarding the conventional and the robotics. So I would always put a word that conventional would be always the better one and the best one, but robotics is an assistive technology. It helps us more in patients. Suppose we have a lot of these patients in ICUs. Now the concept is you mobilize them earlier, the recovery is much more faster and better. So we have a lot of things to do with Hokoma Erigo, particularly the Erigo plays a major role in early intervention in the early phases. Suppose we can also use it for the coma stimulations along with Erigo can be done. And we have the GCS scores of the patients improve very well when we start with Erigo in the acute stages and gradually progress them to the Locomat. As in the Locomat, it was the augmented feedback and the virtual environment. Everything helps the patient. It gives a very good feed. See, I think I definitely am sure that with this robotics, we have the patient's motivation is much more better rather than in a conventional therapy. Robotics has an upper hand on taking the motivation. So, but whatever the equipment does, it has to be manned by the physical therapist and the occupational therapist and the speech therapist play a major important role. So it's always the conventional in adjunct with robotics can help the patients much more better, Dr. Seema.
Thank you, Dr. Raj. And Dr. Hannah, over to you. So you have some special comment with your years of experience and interaction with your
No, I enjoyed listening to everyone. Each and every speaker was very enlightening to each one of us, especially Dr. Renjen, his faith in physiotherapy, speech therapy, occupational therapy, supporting the team, multidisciplinary team. I really enjoyed it. And I totally agree with what Dr. Raj Prasanna says. And public health is another, important subject, passion that I have. So always look from that point of view. And I totally agree that when in the acute stage, movement is so important. So, making use of that definitely along with robotics would go a long way for every patient. But having accessibility to it is also a question at times.
So thank you so much. So I would like to take this moment to thank each and every esteemed speaker who has spoken till to the depth of the information on stroke recovery, which is a topic of concern globe across. So thank you all for taking out your precious time to be a part of this webinar, to share your rich experience and knowledge on stroke from neurobiology to neuro rehabilitation. I would like to express my gratitude towards the current leadership of GAPIO and Professor Dr. Anupam Sibal, the Group Medical Director of Apollo Hospitals, for his constant support and vision for enabling such a platform, which we could help to break the glass ceiling and provide superlative healthcare services. Like today, we have all the experts from all across the globe who are sharing their knowledge and hands-on experience, be it robotic, be it conventional, and how to amalgamate both of them and get the best out of it for the patient care. So thank you all. Lastly, I would like to thank all the members of audience for being here in this webinar, which is almost overseeping by 45 minutes at your time zones also. So thank you so much for making it a lively and interactive one. Hope you all have a great evening, and I look forward to seeing you in the next GAPIO International Webinar Series, what we keep once in a quarter. And we try to make it for people, for the community at large to really understand. And today, with this webinar, I wanted to convey that multimodal approach can be the best approach for patient care. So I hope and I thank all the speakers from core of my heart for sharing your time and all the expertise with us. Thank you, everyone. for
Thank you
joining
very
us.
much.
Thank you, sir.
Thank you.
Thank you, Dr. Sapna.
Thank
Thank
you.
you, Dr. Hannah, Dr.
Thank you,
Raj,
Dr. Seema.
and Dr. Teck and your colleague. Though we oversee the whole stuff, but yes, it is a matter that yes, we need to work towards technology, adapt it, and with best of our knowledge as an expert, should utilize the technology to deliver the best in care of community and patients with disability.
Fully agreed.
So,
Thank you.
so
Thank
very
you,
much.
thank you.
Thank
Have
you,
a
everybody.
very good night.
Good
Thank
night
you.
and thank you.
And thank you so much for joining. Thank you.